Thank you everybody for coming. We're just going to get started.
Hi everyone, thank you for all coming today. I make a motion to start the meeting, second by...
Second motion?
Second.
I second.
Jimmy second. Okay.
Thank you for coming. My name is Jim McGoldrick. Let's say the Pledge of Allegiance, please. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, Jimmy. All right. Just going to start out with, there was a sheet at the welcome table when you came in. It's a little information about what this board is. It's called the Second Precinct Level Advisory Board. What it is it's a component of Suffolk County's police reform and reinvention process aimed at making policing more community-centered. Was the recommendation of creating Precinct Level Advisory Board, formerly known as Precinct Community Advisory Councils. Precinct Level Advisory Boards, PLAB, so P-L-A-B, are an organized approach to cultivate long-lasting problem-solving partnerships between Suffolk County Police and the public. Volunteer community leaders on each advisory board who span a diverse array of backgrounds and experiences will liaise between their community and precinct to facilitate lines of communication between both parties and assist with enhancing relationships between the police and the community. The duties of the PLAB will involve enhancing police-community relations, serving as liaison between the police department and the community, reviewing and providing a community perspective to recommendations concerning programs and effectiveness of the precinct services, promoting the precinct's existing monthly community meetings to solicit public input regarding police services and programs, promoting public awareness of county programs and services, including but not limited to business and residential crime prevention programs, safety training, domestic violence intervention, school district police relations. So this is what we are here for. So this is separate from the monthly precinct community meeting. These questions were kind of accumulated from prior PLAB meetings that we've had and from our board as well. So every quarterly meeting, we're going to have a presentation from SCPD on a specific topic that is relevant to the concerns and issues and questions of the community. So that's that. So thank you. Rhonda. Oh, I'm supposed to introduce everybody, sorry. My name's June Margolin. I am co-chair of the Second PLAB, and in my day job, I am president of Huntington Matters, a community organization.
I'm Karina Mendez, and in my second job, I'm co-chair with June. I work for the Huntington School District as the community liaison.
I'm doing my.
Yeah.
Hi, I'm Rhonda Gooden. I am a business owner at 431 New York Avenue. I'm my second job, Town of Huntington, star exemption specialist, and many other hats, but those two are the main ones.
Diane Shaver. I'm retired from Huntington Hospital, and my job is Director of Huntington Matters with June.
Hi, my name is Kevin. Currently working at Mazda.
Advisor. You're an advisor.
Oh yeah, and I'm one of the advisors at the second prison where the police exploded.
My name is Jim McGoldrick. I'm a lifelong resident of Huntington Station. I just try to get involved in my community and make things better than they were. And I'll be honest with you, I gotta thank the Suffolk County Police Department because that's come a long way in the last 15 years. Thank you.
I'm Ken Patrick Johnson, very active community member, small business owner, and happy to be here.
Terrell Dozier, I'm a business owner and a community member, part of the group Long Island United to Transform Policing and Community Safety. Long title.
Lisa Hargrove, President of Board of Directors for Woodland Village.
Excellent. Okay, Rhonda.
So this is our meeting guidelines. We want you to follow them. Basically, do you have a praise, concern, or suggestions for improvement to your second precinct police services? Do you have ideas for a future presentation? There will be a maximum of 30 minutes total for audience comments at the end of this meeting. Please refrain from identifying officers by name at the microphone. Index cards and pens are provided to write your questions or feedback to share with the Second Precinct PLAB privately. This meeting is being recorded, so avoid sharing your personal identifying information like a street name and things of that nature. Please be aware that we will not allow bashing, political statements, or profanity during any of our comments. Suffolk County Police Department Second Precinct officers are available in the back of the room, you can see, to speak privately with you about crime, policing tips, traffic enforcement, or specific neighborhood crimes or concerns. Please be advised that their fire exits from this room are located, points out the exits, right? Point out the exits, and there is a map on the wall near each door showing the exits from each building. Please familiarize yourself with this information. Thank you.
Terrell?
So I'd like to welcome everyone to our second quarterly meeting of the Second Precinct's precinct level advisory board. I think I speak for everyone in saying I believe that we are in for a treat of a presentation as part of the Police Reform and Reinvention Task Force that occurred, I believe, in 2020. The Suffolk County Police Department developed the Behavioral Health Unit, and at our first quarterly meeting, a couple of community members had some questions and wanted to hear from SCPD's Behavioral Health Unit. And so today we have here that unit to give a presentation regarding their work and their role within our community. As June had alluded to, we did have questions that came up in our first quarterly meeting, as well as the board had developed some questions and presented that to the Behavioral Health Unit in advance so that they can speak to them in their presentation. And there are additionally a few questions that we will specifically request the inspector to speak to that were left over from the first quarterly meeting. So I just again want to welcome you all and looking forward to today's presentation.
Welcome everyone, my name is Dan Rivera. Happy to be the pastor of this church, but also on the PLAB. Welcome to our church. And so we're gonna just ask, there is gonna be a time of questions and answers, but it's gonna be held at the last 30 minutes of our meeting together. And if you have to leave early, just please leave your questions on an index card so that we can address them at a later date.
And then you can leave them with Lisa at the end if you have to leave early. Okay? Thank you. Ken?
Yes, okay, I just want to start, I would like to recognize Suffolk County Legislator for the 16th District for this area, Legislator Sandin, Rebecca Sandin. Thank you for coming. And we're going to kick this thing off. I'd like to introduce the inspector for the Second Precinct, Inspector Kevin Williams, who is the best inspector in the county. I had to say it. I had to say it. I had to say it.
This is the white shirt. And then, Inspector, would you like to introduce your officers that you have?
Yeah, so as they mentioned before, in the last meeting we had, there were quite a few questions regarding the way we respond to mental health crises. So we got together and we figured, you know, probably be a good idea to bring in the Behavioral Health Unit. And they're the experts, and they were formed again after the reform process came out. So they're a new unit, and basically they kind of oversee how we do everything, and they kind of are in charge of the training and everything. So I'd like to bring up Sergeant Chris Angola to introduce everybody from the unit, and they're going to do a nice presentation for you. So hopefully they can answer all your questions.
Great.
Hello, everybody. Thank you, Inspector.
Can you put this on?
Being the expert, I don't know about that.
Can you clip that too? It's a microphone that's for the recording. Yeah, it's got a little flippy.
Okay, gotcha.
There you go.
Hello, everybody. Like the inspector said, my name is Sergeant Chris Angolia. I'm the supervising officer of the Suffolk County Police Department's Behavioral Health Section. Along with me are my team members, Officer Bridget Topping in the back, Officer Gina Lauricella, and Officer Maggie Baroya. The Suffolk County Police Department's Behavioral Health Section is the primary liaison between the department and the Suffolk County OMH and along with our mental health partners, Family Service League, members in the back we'll introduce shortly. The Behavioral Health Section currently oversees 3 main programs: special referrals, along with overdoses. We have a telehealth program and a 911 call diversion program. All these programs right now are currently still in the pilot phase, and they're still being evaluated. So what I'm going to do right now is just introduce our team members who each one is in charge and is tasked with overseeing each of the programs. So I'm going to start off by introducing Officer Bridget Topping. She's going to address the specialty referrals and our overdose program. Bridget?
Can you pass the microphone to her?
Sure.
We're all going to be speaking together. Is that a problem?
No, that's fine.
Okay.
As long as you like somebody standing between.
All right, we like
We'll
each other.
break you
That's
up.
good.
We're just gonna sit in the audience.
Yeah.
Okay. Come on. Yeah. Can I use this?
You can.
Flowers out, flowers out. I like this. Oh. All right. All right, we all set? Oh, more people coming in.
The academy. Do the. No. You look like one of the officers that did the civilian. She was in police academy.
a presentation there.
I was. You were. On social media, they took a picture of you.
Oh, we did the Citizens Academy,
Yeah,
and we teach at. Oh, yeah,
Okay.
yeah.
I thought you meant like the actual academy,
No,
like
no,
staff.
no, no.
Gotcha,
civilian,
gotcha.
Yeah.
No,
Yep.
I saw a picture.
We were
I
there.
see it in the-
Yeah. I
Over there.
recognize
It's his
it.
hair.
Yeah.
It's too hot for the straight hair. We can't. Us curly girls have to let it out. We have to let it out.
And I'm so jealous. I would
I
just.
know. I want it so bad too. Anyway.
We always, it's
Sorry. Bunch of girls. Sorry.
Are we good?
Yep. We're good. Go ahead.
All right. Camera, I apologize. I move around a lot. We're gonna have to just get used to the movements. All right, here we go. We're putting on the show. All right. Thank you everybody so much for being here. I'm really excited that you all want to hear about the behavioral health section that I, Officer Bridget Topping, am a co-creator of almost 3 years ago. My 3-year anniversary will be coming up August 3rd. I really hope you guys are doing a party or something special. A lot of hard work, a lot of blood, sweat, and tears have gone into this. It is a unit, a section that has evolved over the last 3 years. We are building the plane while flying it. We are learning from the community as we move along. We are taking in lessons from what you have to offer us. And like I said, we are continuing to just grow and really excited about the future as to what this is going to look like. Now, everybody has said a couple of times that they had this whole list of questions. These questions just lead me to believe that you guys are very aware that there's a mental health crisis going on. That's excellent. So everybody have a good night. We can just head home. No? We want to hear what we're doing? All right. All right. So the behavioral health section, 3 years ago, a lot of this information, what I read on these questions, somebody has some insider information. Some of the terms, some of the definitions of things that are used are old. Like I said, we have evolved, we have grown. So I'm not going to be answering these questions specifically. I'm just going to tell you about what it is that we're doing, and those questions will be answered as we move along. So I'm going to talk about our specialty referral program, and that has evolved over time. So what that is we are given the names of an individual who is in a behavioral health crisis from community members that are told by their COPE officers. So the COPE officers from each precinct can give us a person's name. We get that from all of the different commands within the Suffolk County Police Department. We get a lot of referrals from our Internal Affairs Office. We get referrals from criminal intel detectives, from financial crimes, but the most important referrals that we get are the ones from our patrol command, because those are the officers with boots on the ground that are dealing with the individuals in crisis and know who they are on a daily basis. What do we do with these individuals? We take a look at them. We look at their whole history, and we refer them to our mental health partners at Family Service League. You guys are sitting down? Jeez. I promise, they work harder than this. We refer those individuals to Family Service League. We let them know if that person has a history of violence, how many times have they been transported to a mental health hospital prior to us being alerted to them. We let them know if they have a pistol license, all very important information that they need to know, because they are the ones that are going out. Their mobile crisis team will go out and look to assess that individual. What's important about this is we continue to communicate about that person. If that person is continuing to have police interaction, we can let them know. If it is an individual that is already connected to services, we can have conversation with their treatment provider if consent is signed, if consent is allowed to that. And we can let their treatment provider know through Family Service League that that person is having police contact, frequent police contact. So this is a very important program. It is one of the original programs that was first started by myself and my co-creator. And it's just, like I said, it's continuing to evolve. Something that we noticed over time was an increase in juveniles in mental health crisis, right? We're all aware of juveniles in mental health crisis. So we are referring now, when we see a juvenile has their transport to a mental health hospital, we refer them right away to Family Service League, who their mobile crisis looks to do the outreach. On the same exact workflow as that, we are referring to Family Service League every Narcan-administered opioid overdose. So that is, we learn about those individuals through a computer program. We have an analyst at headquarters that can send us that information. And it's the same exact workflow. We let Family Service League know, do they have a history of violence? Have they overdosed before? Just a snapshot of what they look like, so that their peers can outreach in the safest way possible. Family Service League will speak more about the outreach that they do when they go out to those individuals, when they get up and talk. Let's see. All right, so I think I'm gonna stop with that. We could come back to me again. My beautiful partner officer, Gina Lauricella, is gonna talk about call diversion. Oh, steal the cubicle.
I don't pace back and forth. I can't. I have to just stay at one spot.
Do you know how many steps I just got in?
Sorry. I have to focus. Okay. So I'm going to talk about what call diversion is. It's a program for when a person is in crisis, they get immediately connected to services. This program doesn't require a police officer. Myself and Brooke, the director of Family Service League, go up to headquarters and we sit with the call takers and we try to educate them on people that would be good diversions. So what happens is the call taker will get a call from somebody who's in crisis. They read through a script of questions. So the questions are, do you feel like hurting yourself? Do you want to hurt somebody else? Do you have access to weapons? If all those questions are no, they then say, would you like to speak with somebody on our crisis team? The person says yes, and they get diverted over to Family Service League. If they're speaking with Family Service League and for some reason something changes, right? We know things change by the minute with people, then they can get diverted back to the call center and then they can get a police officer. If not, and they do speak with that person over at Family Service League, that's where that call ends. The police officer has nothing to do with that call, and they are with somebody who is qualified to speak to. And it keeps patrol, the best part about call diversion is that it keeps patrol in service and it directs these people immediately to the care that they need. Also, the call takers will give us referrals when we're sitting up there, and they'll say, hey, I'm sorry if there's a Mrs. Smith in the audience right now, but hey, Mrs. Smith calls all the time. You know, she's called, 3 times today and 5 times yesterday. Can you maybe look into it? I'll then take that information and I'll do a referral over to Family Service League. So we try to figure out what's going on with Miss Smith and get her the resources that she needs. So that kind of sums up call diversion.
Great job. Thank you.
And Maggie's going to discuss.
Pass the
Oh,
baton.
pass the baton. Sorry.
Pass that.
Yeah.
There we
Thank
go.
you so much.
Okay. Another program that we are working on that we're really proud of as a department is our telehealth program. You might have used your telehealth program just with your regular doctor, but what we are doing as the police department is using that telehealth technology for people with behavioral health crisis, experiencing a behavioral health crisis. In the past, before this program was implemented, responding officers really only had one choice when responding to somebody with a mental health crisis. It was either do nothing with them or take them to CPEP. But what we're seeing is that CPEP is not always the most appropriate care for someone that's in a mental health crisis or a behavioral health crisis. Sometimes really all they want is someone to talk to, right? They don't necessarily need the emergency room. They need a friendly ear and somebody to work through what they're going through. So our telehealth program involves officers responding. If they make it through those questions and the call taker does determine that a police response is the most appropriate thing, the officers can go to that person's house, talk to them a little bit, see what's going on, and determine if a telehealth call is appropriate. So with that, we can use the person's phone, a house phone, anybody's phone, and contact our partners at Family Service League. We'll give them a brief history of what's going on, the person's name, what we're there for, and they can send over a link to directly see that person face to face. It's not FaceTime, but it's something, it's like FaceTime, a video call, a Zoomer, if you will, that we can talk, they can talk to that person face to face, figure out a little bit more about what's going on and go from there. See, is an outreach appropriate? Maybe their mobile crisis team can go talk to that person either immediately, tomorrow morning, whenever they feel like it's appropriate. They can ask the person, come to our facility at Dash so we can talk about what's going on. Or using their expertise, they might think this person is in a behavioral health crisis that they do need to go to the hospital. So they can direct the officer who maybe doesn't have that background to take that person right to CPEP. So it's just a whole lot of options that we can now exercise instead of just that automatic, you called, you're going to CPEP, or we're not doing anything. So it's just more options, yes.
Can you just explain what CPEP is for people who don't
Oh, sure. CPEP is the psychiatric emergency room in Stony Brook Hospital. It's a 939 hospital. It's where officers take somebody who is experiencing a behavioral health crisis, and it's like an emergency room for mental health.
Thank you.
Of course. So that's our telehealth program. We're expanding it as often as we can. We have officers that are CIT trained. We'll get a little more into the CIT training in a minute. We have 20 phones that are department issued. Officers, I don't know if you guys know this, but the, police officers don't have county issued cell phones. And we are not supposed to use our own personal phones for anything. So we have these 20 phones that are department issued that these certain officers can use for that telehealth program, or if those are not available, we can use that person's phone. Okay?
Yeah, and
Oh.
I think what's important to understand, and just to answer some more of the questions that are on here a little bit, is everything that we're doing is a collaboration, right? So telehealth, call diversion, the specialty referrals, the overdoses. It's a collaborative effort in all of this. I just read something, I'm also a newlywed, that marriage should not be based on compromise. Marriage should be based on collaboration. And I thought that was a very interesting way. It could be a play on words depending on how you read it, but I like to think that it's a collaboration, and I know the wonderful collaboration that we have with Family Service League, it's given officers another tool in their tool belt, right? We often refer to our duty belts, what we wear, as our tool belt, what we have. So Family Service League has become another tool in the officer's tool belt to help them make the decisions, because I mean, I don't know if you guys have had, some of you said you did the Citizens Academy and stuff, if you've ever had the opportunity to do a ride-along. People just have no idea the breadth of to which officers have to be knowledgeable in so many different aspects of what's going on. We are marriage counselors, we are therapists, we're doing all of it, and it's just truly amazing. So to know that we're able to give them just a little bit more help, more advice, another person to talk to. Before this unit was even created, I used to call Dash just to run that by them, just to run something by them. Hey, what do you think I could do with this, this individual in crisis? So they've been a marvelous resource to the department. I think that's good. We're going to talk a little bit about crisis intervention team training. Before that, one of the questions was how does the behavioral health section what was the word? Intervention. How do we intervene with the people in crisis? We don't. We sit in our offices all day long. We're not going out. We don't leave. We sit at computers. We're chained to them. Boss man makes sure of that. So we're not interfacing with anyone just yet at this time. We let them do that. So do you guys want to now present what part of this you do? Do we want to do crisis intervention team training first?
Underscore the relationship we have with them a little bit more, right?
Go for it. Yeah.
So, you want to introduce me? Want me to introduce you?
This is Dr. Jeffrey Steigman, the COO of Family Service League.
It's really great to be here. I don't want to take anything for granted. So Family Service League is a large agency, but we operate DASH. So are people familiar with DASH? Have they heard the term? So, yes? Yeah. Okay. So DASH stands for Diagnostic Assessment and Stabilization Hub. And years back, working with the LGU, the Office of Mental Health, Office of Addiction Supports and Services, we realized that there was a real gap, a large gap in the bigger system. And that was really what Bridget was talking to in terms of the options available when someone either needs treatment, is in crisis. It was in the past a real binary choice. It was either go to the emergency room or try to access, get an appointment, outpatient, and try to find access with a provider. And access, as we know, is very difficult. So we knew that the system needed to evolve and change, and we, working with the LGU, we were awarded an RFP to develop this crisis stabilization center. So our center has 3 components. It's a crisis stabilization center, which is in the Hauppauge Industrial Park, 90 Adams Avenue, and attached to it are 2 very important components that kind of fill out the crisis continuum: mobile crisis teams and a 24/7 crisis hotline. The stabilization center is also 24/7. Anyone who's in crisis can walk into the center at any time. They can call the crisis phone number at any time, 24/7. And we have our mobile crisis teams. So really, when Bridget was talking about, tools in the tool belt, we have partnered with Suffolk County PD over the last several years. And what I would say, the DASH program is still our baby. We opened in March of 19. As an agency, we're so proud of it because we've filled that gap and we're making real changes. And the changes that we're making with Suffolk County PD are also not insignificant. They're really, there's been an evolution. So what I always say, Bridget used the term, we're building as we're flying the plane.
That was a good one I came up with.
So we're moving the proverbial needle. We're never satisfied. We're always aspirational in terms of how we want to fill gaps, how we want to provide the right service at the right time in the right setting by the right professional, right? So we know, as Bridget was alluding to and others, that there are times when the best person and the first point of contact should be a mental health or behavioral health professional. And we are re-engineering the system. So just to give you an idea also of the numbers and some of the stats. So we see over 400 people at the stabilization center a month. We engage them at the center. It's not only engaging them in dealing with the crisis, because we don't want a revolving door. We want to be able to intervene at that critical time, right? Because you need to, there's so much research that says outcomes will be better if you're able to intervene and address a situation when it crops up. So we deal with the situation as it crops up, but we also want to make sure that we're providing linkages and aftercare. We do follow-up. So so once the crisis is dealt with, what do they need to be linked to treatment? Do they need other ancillary services? Do they need housing? Do they need food? Whatever it may be. And the team at DASH, so Melissa Kasha is the Director of Clinical and Crisis Stabilization Services, and Brooke Morris is the Clinical Director. Their team and the team at DASH are just, there's such a passion, and if you're there, it's palpable. Not only do all the components work together, but they're so mission driven in terms of really trying to do the right thing, and that's our motto, do the right thing. So at DASH, we see over 400 people at the stabilization center. We engage over 100 people in the community through our mobile crisis teams, and we field over 1,600 active crisis calls through our hotline. So anyone that calls this, the well-known number in Suffolk County, 952-3333, is there, that's going to be connected to one of our licensed professionals who handle the hotline calls. When someone presses 1 for active crisis, we average about 1,600 calls a month. And there are various dispositions that can happen from the hotline, right? They could continue to talk and support that person and de-escalate the situation. They can arrange for transportation to bring that person to DASH. They can dispatch mobile crisis. They can provide linkage. So there are a lot of different options. And as we talk about, one option at one particular time may evolve and change at a different time. So nothing is static and everything is dynamic. So that's a brief overview of DASH and the crisis services. We try in many ways to bridge gaps, as I mentioned. So on our agency website, as an example, any medical provider in Suffolk County can go to our website, and it's on the last tab on the website, it says outside providers. And there's a drop down for medical providers and SCPD. So SCPD shares information with us through that, but they're also, any medical provider can go and fill out a one-page referral form and link any of their patients that need behavioral health to DASH. Basically, the referral comes in, it gets ingested by our electronic medical record, and the staff at DASH get alerted, and then we will do a telehealth assessment. I can't say enough about telehealth because really it's a change in culture, right? So to be able to get to the point where we're at, where we're looking at things saying, all right, the only way we're going to change the outcomes is if we try something different. So using telehealth in the way that we're using it, where we're really decreasing geographic barriers, we're responding in real time, and what I could say is that of the 80 to 90 requests for telehealth referrals a month from just the police department, we have a dedicated law enforcement line in DASH that was set up just for law enforcement. They will call that number, request a telehealth, because again, if it's a clear-cut case, the police can use their powers and take someone to the hospital. If someone is suicidal and they have a gun in their hand, they're not going to call us to say, should we take them to the hospital? Right? But most of the cases fall into that gray area. That's when they'll call up, they'll talk to a licensed professional, and since we've started in 21, 80 to 85% of those calls get diverted from going to the hospital. So that's a huge savings in terms of the system, right? So you don't take 2 officers out of their sector to take them to CPEP, the Comprehensive Psychiatric Emergency Program, and instead they're talking to a behavioral health professional, and they're coming up with the correct disposition. So I can't underscore that enough. That's a huge change. So I'll stop, because I can keep going. But I want to let Melissa and Brooke talk also about some more concrete things that have come up.
Sure. Okay, great.
You gonna share this?
Sure. Yep. Okay. Thank you so much for having us. I can't say enough about my passion for giving people options when they're in crisis. Jeff didn't even talk about the fact that we have peers with lived experience with mental health, recovery, and some parent advocates that work for us, so that when somebody is in crisis and they need to talk to somebody who's been through it, they have that ability to talk to somebody who's been in their shoes, where as a social worker myself, I may not self-disclose and share that. Options is really the name of the game when it comes to DASH and what it's opened up for the community. The fact that we have so many more options to help somebody and to meet them where they're at and be available when they're maybe ready or having a crisis is so important, because when that crisis passes, sometimes that person sometimes doesn't follow through and reach out for help. And we've had people that maybe come and utilize DASH, talk on the hotline, have a mobile crisis intervention, and even though we de-escalate and we support them in the moment, it's really their choice what they want to do once they de-escalate. Do they want to accept services? Do they not want to accept services? And we have the ability to build that rapport with them, get to know them. We have medical record that, you know what, maybe if another crisis pops up or they call us or they reach out at another time, we remember them and we could say, oh yeah, Mr. or Mrs. Smith, we talked to you last month. And maybe at that point they're ready to make a change and accept services if maybe they weren't ready at the time of crisis. So I think just the person-centered nature of the crisis continuum that we have is a huge piece that I just wanted to talk about for a few minutes. I also can't underscore enough the work that we've done. We've been open for 5 years. The change in our relationship and the way that we are growing and developing with the police is really incredible. As a social worker, I take, a soft approach and I'm there. I know how to support people. The officers that we have worked with over the past 5 years have really grown. We see such wonderful officers really learning and growing through a lot of different things that we've done to help support people in crisis. And it's a huge culture shift. Not every officer is going to make that culture shift at the same time, and we're a huge county, so there are a lot of different officers that need to make that shift, but we're working very hard to make that happen in a few ways. Are you going to talk about crisis intervention training, or would you like me to talk a little bit about it? Okay, great.
We'll jump in.
Okay, great. So crisis intervention training it's really a police department initiative where they are training officers, a week-long behavioral health training where they cover a variety of different topics. Brooke and I have the pleasure of going and we present to the officers every single time they've run it. Since they started this a few years back, we are always there. Her and I make ourselves available and we go and we provide a block. And in that block, we talk about DASH and we talk about these options so that the officers are well informed to know what are other options other than taking somebody to CPAP or walking away from a behavioral health crisis. We talk to them about how they can connect with us, that dedicated law enforcement line. We talk to them about the telehealth program. We answer questions just to help build the understanding and bridge that gap between us. We also bring a peer with us now, which is really amazing. So we have one of our peers actually present on their lived experience and explain to the police officers what their role is and how they can help and how it's a different form of help that they might not be familiar with. The CIT training really covers a lot of different things. It covers mental health symptoms. It really educates the officers as not behavioral health providers on what to look for to help them understand when they're maybe responding, maybe not things that they would recognize in the past as a behavioral health emergency, might stand out, it might trigger something that they know that they can call us and consult with us and we can try to talk to that person. We also, do you want to talk about the recruits a little bit?
Well, sure.
Yes, go ahead, Bridget.
So just with
yes.
CIT, I'll just
Yes,
yell
just-
into your microphone.
Yes.
So just what CIT is, just to elaborate on Melissa's and Brooke's part in it. CIT is a nationally based program that is, again, that magic word, it's a collaborative training class. So there are some standards that have to be followed for that. It is driven to be volunteer based, where we want the officers to want to take the class. 20% of the department is trained in CIT training. Our in-service department actually leads the CIT training. So we go in and we just explain to the officers what it is that we do, that the behavioral health section exists, what we can do for them. And I think we put out about 8 to 10 one-week-long classes every single year. And each class ranges from about like 15 to 30 people, all depending. We do train other departments as well, are allowed to come into that. But like Melissa said, peers come in, so it's not just Family Service League that'll come in, OMH will come in, somebody from Assisted Outpatient Treatment will come in, and it's just, we look to take officers that have had a couple of years of some training and experience under their belt, give them the opportunity, if they choose, to take this class so they can be CIT trained, and just almost update them on what is going on, what things have changed, what is new, what is different. Meet Family Service League, meet the behavioral health section, meet the people that are asking you and telling you different things throughout, you know, the different community entities, group homes, whoever it may be that you're going to. So it's a great class, and that started in 2019, January of 2019.
The same year we opened,
It was
yep.
the same time, it all
Yes.
happened at the same exact time. And it's just really, in the 5 years of that, it's amazing to see how we have grown, so.
Yes.
All right, go ahead.
I'm going to stand on this side of you, right?
Go ahead.
So part of the additional work that we do over at the Training Academy is the recruits go through a very long training process. Sometimes they spend in the classroom, other times they spend,
It's over you.
thanks. Other time they spend obviously doing physical training. When they're in the classroom, we actually come in and also provide training to them. We talk about DASH, we talk about different kind of situations that they go and give them the same kind of resources that the CIT training also provides to those officers. Then as they go through their recruit training, they also go through an EMT training. Part of their EMT training requires a clinical. So all of the recruits have an 8-hour clinical at DASH. So they actually come in, and it's part of their EMT training. So they're not coming in as police recruits, they're not coming in like with a gun or anything like that. They come in professional plain clothes, and they observe all of the things that we do at DASH. So they see what we do as far as hotline calls. They see how we de-escalate someone. They observe going out onto mobile crisis and what that looks like. They may see some of our other programs, some of our follow-up work. They spend time talking to our peers to understand all of that. And what's been really nice seeing that transition, we've put almost, I would say about 600 recruits, maybe a couple more, since we've begun this process. And because the recruits are not only Suffolk County Police Department, they're from others, as their police department training academy allows other police officers to come in, it definitely shares a lot of information very broadly. And what's nice is that now when we're going out into the field on mobile crisis, the recruits are now seasoned, trained officers, and they're seeing the same folks who they spent some time with. They understand. They're picking up on things. They're remembering certain things from the training, like those gray case ones, so that when they're calling us for a telehealth, they're actually telling us things that they're seeing that they may have not recognized as a behavioral health concern before. So we're definitely seeing a huge partnership with that. And we're also seeing that there's a huge shift in how our clients or our guests, how they come in when they're coming in with law enforcement or even engaging with them. It's definitely a softer approach, and you see that there's a better partnership and engagement. We have officers who come in and say, like, we weren't sure what to do, but we need help with this person, so we called you. We don't know, we're unsure, but they need your help. And we've seen like this huge nice shift transition in the community as well, with how they're using and thinking about other options outside of just going to the hospital or just leaving a scene and saying, oh, I wish I could have helped that person. So there's definitely been a really nice cultural shift overall.
And if I could just add, the longevity of the relationship, and really, when we opened DASH in March of 19, it took about a year prior in terms of planning. So as I mentioned, it was a new level of care. So the relationship with SCPD started a year prior, if not a little bit before that, just in terms of they were at the table in the planning process. We worked and trained all and kind of opened up dialogues with all the officers in all the precincts to say, all right, what is DASH? What's the DASH model about? How is it different than the hospital? when would you bring someone to the hospital versus bring someone to DASH? And we really came up with scenarios, opened up dialogues, talked about real case examples. And I think that was very helpful because we do keep a lot of stats because it's very important to look at outcomes. And I mentioned before, we see over 400 people a month. And again, consistently, only 1 to 2% of that number have to go to the hospital once they go to DASH. That's a very low number when you look at the national stats.
Sorry.
And
We're the monitors over here.
so it goes back to crises. You know, anything can happen at any moment, but that's a very low number statistically. And we're proud of that, but we're also proud because it's part of the work that we did and what we laid in terms of the foundation, in terms of the training. So I just wanted to add that piece.
You want to go on my shirt?
One other thing I wanted to mention, as part of the Suffolk County Police Department, they also have supervisor school. That's what
Yeah.
Are you going to talk about that?
I was going to say, yes,
Oh.
so just, we also speak at any training opportunity that the academy is hosting, whether it's field training officer school, SRO school, which is school resource officer school, to the recruits when they go through their, their mental health training, supervisor school. What else is there? There's a lot.
Detective?
Yeah. Anytime there's an opportunity when we can speak to the police department, we do. We let them know how they can reach us, because like I said, all of the referrals that we get, they're coming directly from the boots on the ground police department. So it's just really important that our brethren know who we are and how they can reach us. And just, if everybody understands what an amazing job the Suffolk County Police Department and the government itself has done. We've had the backing of the Ledge, we've had the backing of the CE's office, even as we change now. They've already come and sat down to meet with us to hear about what it is that we could do, how they want to know, how they can help. What more do we need? What do we want to look at? So everybody is really, like the government, they're really backing us. They're really supportive of us and everything that we're doing. And there's been a lot of changes in the last 3 years as far as, we have the body cameras now, we have new programs rolling out, and I'm really proud of my officers that are out there taking in all of this new information, this new learning, these new skills. I've been a police officer for 20 years, and the most change I have seen in the environment of policing is in the last 5. It's very significant. So, and I'm proud to be part of, I almost lost my job on my first day, right? Because I said, we got to change this. I don't know, I don't like it. I want to be a solution. We need a solution. And my boss at the time said, Bridget, you can't talk to them like that. And I said, yes, I can. Oh, I'm so sorry, Melissa and Jeff. I'm not allowed to talk to you like that. But it's been great. And you're dealing with people up here that we know there's a problem. Everybody knows there's a problem. You could all tell me a problem, and I'm going to tell you I know that already. We want to be part of the solution, and we're working on that. So it takes time. All of this takes time. Everybody that they interface with, anybody that we talk to, this takes time. But in 3 years, what we have done and what we have implemented, I'm not just tooting my own horn, it truly is amazing considering the changes that we have gone through. I've had 4 different titles, names, numbers, it's just, it just constantly changes. So very proud of us and the team and everything that we're doing. So I guess, questions? Do you?
Do you want to take questions? You guys want to take them?
So are you guys done with that bit?
Anything else?
You guys done right now? So here's the thing, just to keep everything consolidated, we had also a list of questions for the inspector that were slightly different topics. So we'd like to let him answer his, and then we all ask everything about everything afterwards.
June, are we going back up there?
No,
Oh, okay.
not right now,
Okay.
right? No.
You want to give them their
What do you think?
questions and let them
Up
go?
to you guys. It's up
Why
to
don't you,
you guys.
anybody have questions for them?
Would you like me to take that?
Yeah.
I'll take it for the So the question was 988, and that's now the relatively new 3-digit number that someone could call. It used to be the National Suicide Prevention Helpline, but it's basically a nationwide network of of crisis. It's a crisis hotline throughout the country. So we are actually, like I mentioned before, we have the crisis hotline as part of the DASH and part of our continuum. We are actually in Suffolk County a backup to Suffolk County, which is the primary is Response of Suffolk County. They are the primary 988 provider, but we back up Suffolk County, Putnam, and Rockland County. So our hotline handles 988 calls, but also all the calls in Suffolk County that just come from the 952 number.
I also want to just talk about how important like the continuum of care and our relationship with providers. We have a very good working relationship with Response, who is the main provider, so that if they need mobile crisis or they need to use the DASH services to divert somebody from going to the hospital or calling 911, we just had a call with them today where we got consent from somebody that we work with, they've been working with, so that we can partner together and make sure that person gets to the right level of support when they're calling them. So we work closely with Response as well. I just wanted to underscore that.
That's great. Anybody? Thank you. Oh yeah, raise your hand if you have a question. I'll bring the microphone to you. Oh, just go ahead. You ask.
Well, thank you so much for transferring all this information. I, for one, am very interested, but I'm overwhelmed, and I would like to recap in some way. Can I read about this somewhere?
We do have information. Why don't we connect after, and I'll send you some information.
Great, thank you.
Perfect. Raise your hand if you have a question. Terrell.
So I'm really interested in knowing like what data you guys collect regarding the regarding like calls that come in. How often is it, like what % of calls get flagged as being potentially a mental health crisis that goes to maybe the call diversion program, or has an officer potentially go out, and then like what data is really collected by the unit related to
We are capturing all that data, both us and Family Service League, but it's all in the pilot phase as of yet still. So that is just information that we have for us.
Okay. And are there any particular like metrics or indicators that you're specifically looking at, even if you don't have like, 75% of this or whatever, but like, are there any specific metrics that you are looking at to determine how successful the program is?
Yes, there are.
Can you share those?
Our metrics are constantly evolving and changing as we move along through certain parts of this program. Like I said before, there have been some internal changes within the police department where we've had to constantly move the needle in certain ways. So that's why everything is remaining in a pilot, and that's why we are continually looking at our metrics as in periods of time instead of like an overall program. But yes, we are keeping all that data.
And so you say pilot, and there are more questions, but you say pilot. So is there any thought or plan around scaling the work that you guys are doing? Like, is there, like, because, when I think of a pilot, I think of like an end date, and then there's like, we're going to scale, which I imagine we all would like. So is that like a thinking? Is that future thinking about scaling the program?
Yes, there is, and that is for the bigger bosses at headquarters to determine when they are satisfied with the work that we're doing. Like I said, we're only 3 years in. It's a very new program. We've had a lot of change, a lot of involvement, so there's a lot. So it's all being kept, and when the powers that be say that information can be released, it will be released. But if you go on the Transparency Hub on Suffolk County, the police website, all the information about the police reform, everything about like, the percentages and data, there's tons of it on there on the Suffolk County Police Reform website.
They'll give you the breakdown to the mental health
Yeah.
calls that we handle, the
Oh,
overall calls that we
okay.
handle.
Oh yeah,
and the
that's all.
transparency.
It even
and the
tells you
transparency.
our ages. Right now, there are 67 police officers that are 41 years old. I'm one of them. I didn't even know that. 67. They break down everything. So whatever what you need or what you want regarding all of that, that's all on the Suffolk County website. You can go on.
And then what you're saying about the pilot has to come to a point where, well, like Brittany said, you know, the metrics may change, that criteria may change, and we're evaluating that and then seeing what fits best and then go from there. So
Based on resources, time,
that's really what, you know, what we're coming to.
And one more question, and now pass the mic. I apologize. So I'm really interested in knowing and thinking about the protocols that just like beat cops have, right? So just they're walking the street, they're the patrol officers, right? And so you know they come up with an incident that might be a crisis. Like, what are there any protocols provided to the patrol officers to help guide them to when they should be making the call to the telehealth unit per se?
Training and experience. That's what it's going to be. Training and experience. What they have, their intuition, and they get trained in the academy, and through their experience on the streets, they're going to make those decisions.
You know, we do have rules and procedures and guidelines, and that's just what they are, guidelines. Because you can't give facts and instruction on every scenario that's out there. There's a human factor to it. So, and like Bridget was saying, it just comes with experience and training. And you kind of, you know, put those two together and you try to, you know, use your best judgment. You know, they're talking about the telehealth program. You know, when we receive those persons in crisis calls and they're dispatched to the field, you know, the telehealth is another tool, like they were saying, on the officer's tool belt. That telehealth will give the officer, you know, assist that officer in triaging that person. Again, just, you know, more information on how to handle a certain call. So again, with the telehealth and some of the programs that we're laying out, you know, that's what's assisting the officer, and that's what's, I guess you could say, you know, how they're evolving into handling these calls. You know, it's the training, the experience, the tools, the new tools that we're giving them, the partnership. So that's kind of how it's all being brought together. Because you can't give anybody, you know, on this call you're going to handle it like this every time, because what may work with you will not work with this gentleman over here. So you really can't. It's guidelines, and, you know, training and experience.
And Terrell, there's one thing I wanted just to add. I mean, it's just, you know, if you think about it, in the past, there was that like binary choice I was mentioning, and with, you know, with the ability to now that we have this collaboration, we want to take the police out of what was the de facto, you know, behavioral health professional, substance use, or mental health counselor, where, you know, officers would say in the past, you know, I'm not going to take a chance. I'm taking them to the hospital. Well, a lot of times it was not necessary, and that's where if you have the mental health professional, you know, partnering with you, we can do an assessment that is a different type of assessment that could hopefully, again, the goal being diversion or just getting them to the right place or right supports. And I think we're seeing that quite a bit, if that makes sense.
I'm going to jump back and forth across the Karina?
I don't really need So, the services, when you get a call and it's someone that does not speak English, how do you handle those calls?
We have some bilingual staff that if they're on staff, we have technology and a call system where we have certain call queues where it might route to somebody without them even having to ask. If we don't have that person on site, it might flag it in the system and we can have a translator right on the line when they call so that it's seamless. But we do have to use language line as many hospitals and other healthcare providers do because it's not possible to have staff in every language and always have a staff member of certain languages on site.
Now, the handling of young adults, youth, is that handled directly through you, or do you have another set of social workers that deal with the younger population?
We are 24/7. We cross-train all of our staff to be able to work with adults and children at the same time.
Excellent. Sorry. I'm not playing favorites, I swear. Thank you.
Well, okay. Okay. I need you to hear me. First of all, I give you credit for trying to make change. I do. I have nothing but respect for Family Service League. I was on their board for 15 years, so they are clearly the best. But you, when you talk about the issue, you talk about experience and training, and yet 80% of your officers are not trained, and you really focused on the fact that it's voluntary. If, to me, nothing is more important.
In just the crisis intervention team training, 20% are trained. I didn't say, so.
Okay.
Yes, that's just in a specialized.
So an
crisis
officer,
intervention.
just every single
police
officer?
is trained in the academy in almost a 2-week long mental health training class where they
On
gather all that
de-escalation
shit.
if they're.
All of that is
Okay.
done there.
So what about
Yes,
the,
ICAT, yes.
what about the officers who have been here for 15 years, 20 years, and aren't going through the academy? Do they get trained in that same de-escalation technique? Or, because it sounds like it's a new thing.
No, it's not. It's not new. They have all the training. It's grown and it has expanded over years. But everything we base off is our yearly in-service training. So officers do go to training via in-service. That's our in-service team unit that would command that could talk about that. I'm not going to speak to that. But the crisis intervention team training that 20% of patrol is trained in is different.
Okay.
That's
So
different.
every officer.
And that is a percentage that was created by the county executive's office
Right.
that they wanted to see. So we have met that standard, the county exec's office
Got that.
and police reform, so.
So every officer in Suffolk County who goes to a call and somebody's standing there with a knife would know not to say, drop that knife, drop that. They would know that this is probably a mental health issue, or it could be, and that might make it worse. Is there that kind of, that's what I'm asking, is there that kind of training?
Officers are gonna handle things with their training and experience.
Okay.
I can't, I mean.
You know, the way you just
You
described
know what
it,
I'm
how do
saying.
you,
Yeah.
I understand, but how do you
Yeah.
make that, do we know that person has a mental health crisis?
Well-
You know, and it's a heightened moment right there, so, and I understand all that. You know, again, we have in-service training that all the officers have to attend every year, and they get updated on, you know, new protocols or, you know, new training that's coming through. But again, you know, and like I explained before, every situation is different. To give specific rules on every, you know, on what you should do, it's so, I mean, you know, I've been a patrol cop, I was a patrol cop for almost 20 years. I've hundreds and hundreds, maybe 1,000 mental health calls. I mean, probably not one did I handle the same. The way I spoke to different people, you know, some people were more agitated than others, and my de-escalation techniques may work on one but not the other. So, I mean, it's very difficult to, like what you just said, you have a knife, drop that knife. I mean, the scenario, you have to give a lot more to that to really have understanding of what's
It's gonna
going
be
on.
totality of circumstances.
Okay.
And we don't.
I won't comment.
I just want to have some clarity, just a little bit, that if I call because someone's in psychosis, would it be handled differently depending on what policeman came to the situation? Do you follow what I'm saying?
No.
Well, you're saying about the gut and this, well, I just wanna know, like, there's not a real protocol, like if they're in psychosis, if they should call DASH or whatever, it's like your decision?
Yes,
of
it's
how
an
to treat
officer's
it?
discretion as to how they're going to handle every single call.
Yeah, well,
Yeah.
it makes a difference on who comes to your house.
Absolutely, and believe me, you know, officers are more scrutinized now, especially with the body cameras than ever before. They know, you know, they are, they're the show. It's, you know, and I'm for the body cameras. Let's make that clear. But just anyone here working, if I had a video camera of you all day on your job doing your tasks, it's a little, you know, it raises your, you know, your stress levels a little bit, and you know they want to do the right thing, and they're gonna do the best of their ability. They're gonna try to make the right call. You know, do sometimes people make mistakes? Absolutely. You know, we're only human. We're not, you know, superheroes. So, you know, I can only, like what you're saying there. You just, you know, again, it's their training, experience. Unfortunately, I don't say unfortunately, but you know, right now we do have a lot of young officers, so they're going to rely, but they have that training right behind them at an early time. So, you know, they're relying more on their training than maybe their experience at this time. You know, the 10, 15-year veteran, you know, he's relying on his training, but his experience that he's dealt with, you know, people throughout his career. So, you know, it's a balancing act with the two.
Do you have close contact with CPAC? I mean, do you give them the history of?
With who?
CPAP.
Oh, CPAP. Well, we refer individuals to Family Service League, and then if a person gives consent, it's all about consent, right? So it doesn't, you know, they can speak more to that, but we all have a relationship with CPAP, yes.
So if they don't give consent and they go to the hospital, then Dash
With
can't give
information sharing.
information.
Yeah, so if it's a crisis, we share information, because we want them to understand what's happening, what we've observed, the relevant facts. So that information is shared so that they can do the best assessment and then make the best determination. But, we have, just like the police have certain powers, we have certain powers to say this person does need to go to the hospital for an evaluation. It's the minority of times, but once they get to any hospital, I mean, right, because CPAP, as Maggie was saying, is a receiving hospital, so it's like, the central hospital for Suffolk County, the police take them there unless they're on diversion. But once they get to a hospital, then, we give them information to help them and to make the best informed decision, but they make their decision. They're gonna make their decision based on their assessment.
The problem is when someone, doesn't agree or doesn't wanna get help. I don't know how you handle that.
And that's a difficult area, because, if I turned around and then said, all right, everybody that we think is suffering, we're gonna lock them up, well, of course, we're not going to do that. So people have rights, yeah. So, you were asking before about rules, and guidelines. Well, yes, we do have rules. When we respond to a mental health call, our criteria is if a person we feel is in danger to themselves or someone else, that's what gives us the authority to take that person to the mental health hospital, okay? Involuntary, and at that point, it's out of his hands, or her hands, they don't have a choice. If they don't meet that criteria, and for a lot of years on patrol, that's what I was up against, there wasn't a lot we could do for them. And that's what's so great about this collaboration now, that there are options. There's, we can bring them to Dash, we can connect them to services immediately. So that's where we're seeing this evolve to.
And just to answer your question a little bit further, to elaborate, because this is the nuanced answer that it deserves, right? So someone can be psychotic and not a danger, right? So just because someone is not imminent, right? So if someone doesn't have to be imminently at risk, right? So if someone's imminently at risk, whether they're suicidal or homicidal, that's more clear cut. Someone could be grossly symptomatic, but not a danger to themselves, or they're so grossly symptomatic they can't care for themselves, and they do need to go to the hospital, and then they may get involuntarily hospitalized once they're there based on the doctor's assessments.
Just one question. I know it's a lot, what you're putting together here must take hours, a lot of time, a lot of patience to get it through. But you also have problems with HIPAA laws too, right? There's only so much you can do and talk to each other about because of the HIPAA laws, correct?
It's
See,
really-
because that
it's
kind
really-
of restrains you now to a point.
It's really the mental hygiene law. HIPAA is more permissive. Mental hygiene law is more restrictive.
Okay.
So for
But you're still
confidentiality.
restricted in a lot of the things you can do.
Yep.
Okay, thank you.
You're welcome.
What's up?
Okay. What if a person, for example, if they have been subject to theft or break-in, or their lock has been tampered with, it's not the person that needs help. They don't need any kind of mental help. They need the police. So what do you do in that case if you see that for example, if you see that your lock has been tampered with, and you might call the police and show them, and then if they think you're crazy, but you're looking at your lock and it's been tampered with, and you have a problem, if you're on the ground floor, you have a problem. And you can't keep changing the locks, that's expensive. It's not the person who's sick. The person needs protection. What happens in that case?
I think that we had a case, let me tell you, we had somebody who was having a problem with a neighbor, and we advocated, were able to get them services, and I think they decided, did they decide that it was best for them? We supported them through finding other housing, and I'm not saying that that person necessarily needs to move. We develop relationships with people, we try to see what we can offer in terms of community resources. Some things you just need to be handed off to the
Hi, I'm here representing LA United, the Transforming Crisis Response Group. We've met before, and it's great to hear some of the updates. Particularly, we're really pleased about the call diversion and how that's grown, so thank you for that. We do have a specific question about the telehealth phones that are provided. So those are county issued, or those are department issued phones. How do you determine who, with so many officers in the field, who gets the phones, and how does that work? Do they stay with one officer?
Excellent question. So those 20 phones are only issued to CIT trained officers. So an officer does have to go through that training, and when we go and we speak to them during CIT, we ask, would anybody be interested in having a phone to use for these purposes? And we track and monitor those calls. So we also track and monitor if the officers are using the phones. If we see that an officer isn't using the phone, we're gonna ask, why aren't you using the phone? What is going on? If they say, you know what, just haven't had the opportunity, I thought I was going to be able to use it more, and I'm not, we can take that phone and we'll give it to somebody else that may have an interest in using the phone. So it's like I said, it's a pilot program that we're constantly tracking and monitoring. We have the pilot officers that use the phone, that are issued the phones, and then the rest of patrol that use the phone.
Are they all in use? They're all in the all 20 are in the field?
All 20 are in the field, yes. Right, Max? Yep.
Okay, thank you.
And just what I'll add to that, Rebecca, the goal is to really connect with the person on their phone.
Yeah.
Or tablet, because if we're doing an assessment and we're able to let the officer know, you know what, we got this, you can go back to your sector, we will continue doing what we need to do, and we don't want it to be discontinuous, meaning that they'd have to get off the officer's phone and then call back on a different phone, etc.
And we do make sure they're spread out across the county. And I know that you're in the second precinct, I believe one of your SROs has a telehealth issued phone. We make sure to have some SROs have it, so when they have a student in crisis, they can connect that appropriately to the family services.
The dedicated law enforcement line, though, is available there all the time. So that's a way in. If they don't have one of those phones, they may call us and we might figure out how we can best help.
Hi. Hi. So I'm a resident of Huntington and had a recent mental health emergency with my loved one. But because of my loved one has a mental health, serious mental health condition, I've been a member of NAMI, National Alliance of Mental Illness, and now I'm an executive director in Nassau County, which is not in as good a shape as this. And Ellen and Jayette are part of Suffolk County NAMI. The point of my question is, so I had an emergency at 2 a.m. So now I'm well versed in emergency situations with my loved one, and my loved one was missing. So I picked up the phone and I called 911, not 988 because I'm a little hesitant. And I called 911, I said, this is behavioral health emergency. My loved one is missing. And I described more in depth about what the scenario was, why he was missing, what the medication condition was, and she's like, okay. I said I would like a CIT trained officer because I didn't know when he might show up, when he went, and what might unfold. And she said, don't have that, but I'm going to put things in action for you because you obviously understand what's happening. The guys will be, the police officers were there in like 30 seconds. I mean, I couldn't believe how quickly they got there. They showed up, they had the dogs ready, like they were looking. They were like looking before I finished my sentence. So I was unbelievably happy. But when everything sort of resolved itself, it took 2 hours, but when things resolved themselves, I said, okay, can I ask you more questions about CIT in terms of what you have available? Because they sent in a sergeant, they sent somebody, again, no complaints. I was thrilled to death. The officers were young, and they said, we're so young, we've never dealt with this before, so let's talk more about what you think is happening. I said, okay. You know, again, it was fine, but I was told that there was only CIT officers available Monday through Friday, 9 to 5.
Oh, that's cute. I don't know who said that. That was a really, like, somebody that dug deep for that one and just was like.
They possibly didn't know.
No, they didn't.
They didn't
I'm going to
know.
tell you right now, that was cute. That was cute. I applaud them for pulling something out of you know where. But yeah. So no, that is not true. Every precinct of every squad, I shouldn't say every squad, but every precinct across the board.
They said one
does
per
have.
squad, and I thought, again, at the moment I wasn't interested in answering that, like, but what defines a squad? I'm like, I don't even know what a squad.
That's just the shift that is working at that time.
Okay.
So that's
So
and
what
that's just how
percent?
patrol-
So we've got, like, in Suffolk County, roughly 1.5 million people, or something akin to that. I don't know how many police officers you even have, but what percent of those police officers are currently CIT trained?
20.
So it is just 20%.
Yes.
Okay. So that's not enough. So what do we do to increase that percentage?
Listen, it's training and it's resources.
So what I was told, because again,
and that is a number. That 20% is a number.
So we have
that
to
was
change that number.
Created by the department and the People's Plan, the police reform, when all of this started.
Right.
That was the number, and we have maintained that
Yeah.
through attrition.
I was
and-
looking it up, I believe there's around 50 officers in the second precinct who are actually.
Well, I think it was
Right.
more that. It was like
but we all know that we're in a mental health crisis, that it's 25% of population, and as we educate the world to make that phone call and make that request, to call 988, to all this, hopefully, that CIT trained officer is in higher demand because the public understands that that is necessary to have a trained person show up. So what I was told is that the state of New York provides free training for CIT, funding for this, but what is not happening is that officers don't have the time or are given the time necessarily to receive that training. I know that sounds convoluted, but it was explained to me just in that way. I didn't, obviously. But again, part of my role as an advocate is increasing this, right? Again, my function is Nassau County, but still in Suffolk, 20% is just not enough. Do you feel that that's enough?
So two things. It's an evidence-based practice. It's a national model. And
Correct.
And if you go to, some of the literature.
I have, because I'm trying to get people trained.
And they basically say the numbers should not be well beyond that. Because as long as you have coverage, going back to what you said about there's a CIT officer on all these different shifts, it is not meant to train everyone in the police department. It is a more specific training for the right people who can respond in that way. And that's the model itself. But the other thing I wanted to mention was, we're very proud of the fact that this was a new level of care, like I mentioned.
Yes.
And the state has really, we worked with the state, and we were the proof of concept for the stabilization center, and there will be many more opening up throughout New York State, and there will be one in Nassau.
Right. There's one, exactly. Let me just wrap my head around this one statistic so I can re-articulate this to all the people that we answer to, is that understanding the 20% and that it's not supposed to be every officer who responds to that. So, and all the advocates in the city of New York who are not pro CIT right now, because there's that suggestion that police are not reacting in a positive way, akin to what somebody was referring to with a knife. And again, I know that was maybe taken out of context, but if we put it back into context, is it the model that Dash and this scenario is going to accelerate to such a degree in that relationship, and that's going to keep in pace, that CIT only needs to be 20% of a police force? Is that the idea? Is that the concept?
I mean, I think, I can't speak to where they got it from, the evidence-based model in terms of who created it and how they got to that number. I mean, I know that it wasn't meant for everybody, but no, I mean, I think we all know the alternatives to police interaction when it's not needed is a must, right? So it really should be the rule rather than the exception, like when we do telehealth and everything else. So I believe that, yes, we need to evolve the whole crisis system, right, as we're doing this, and not just here in Suffolk County, but all over.
Okay.
So absolutely.
Okay. So you still do advocate for the CIT model
Absolutely.
and this whole model?
Absolutely.
Right. So, all right. So I look forward to you guys really publishing your data, because there are so many people. Again, I tried so hard this winter to advocate and get funds and really promote and get Nassau County back into that because NAMI's paid for a lot of training in CIT. It's a low percentage right now. So the point is that I look forward to you guys publishing all of this data and making it, for us all to share. Thank you. I appreciate your efforts.
Thank you. So my name's Emily. I'm also with Long Island United's To Transform Policing and Community Safety Mental Health Crisis Response Work Group, and I think I know Bridget and Jeff back in 2021, Rebecca and myself and someone else during the reform process, we met together. We brought in some of the folks from MCOT in Austin, Texas to talk about some of the work they're doing, their pilot model, how they work to scale up over a decade. And I know they're still continuing to scale and do work. And I believe, and we've had the opportunity for some recent meetings, which I'm so appreciative of this. This is all about community engagement and more transparency for the community and getting feedback also from the community. My understanding is you're doing some work with Harris County, which is where the telehealth kind of program came from, which also some of the work you guys are doing is phenomenal. I did want to give some community feedback, and I have a couple of different thoughts that I wanted to share. One of the things that I think is most frustrating for me as a community member, sometimes in the interactions, is conversation around transparency. And so I'm hearing a couple of different things that I'm trying to hold. I'm really excited about the work that's happening with the Behavioral Health Unit, and I think everyone up here giving this presentation is clearly communicating your excitement about this work. And I'm hearing from the audience there's a lot of excitement. And then I'm hearing this next part that's like, awesome, we need more. And I've looked on the Transparency Hub, and under the reform plan, what it says from the official SCPD position is behavioral health has been transformed, period. But today I was very excited to hear the concept of this being a pilot program, which, as Terrell mentioned, leads me to believe this is an initial small thing that maybe will lead to something further. And it leaves me a little bit frustrated as feedback to bring back to the department. It feels like a conflicting message. At one part, I'm concerned of like, wait, is this as far as the department wants to go? Because I think we all would like more, and I think what you guys are saying is there's a lot of great success and you want to expand it. But I don't hear a message officially from the department saying we're interested in expanding it. I think on a transparency level, one of the things I was really excited to see from the MCOT model, from both their police officers and mental health unit, is they had published kind of their benchmarks, where their current pilot was, what they were hoping to expand to, with an understanding who knows if we get there. But goals and benchmarks, this is where we're at now, this is where we hope to go in a year, in 3 years. This is the vision ahead. And I think as a community member, it would feel really reassuring to hear that kind of long-term planning. And I don't usually hear that from the department. I usually hear more statements of everything's great, don't worry about it. And a lot of things are great. And I also hear the department constantly saying we want to improve. And so I'm holding those things, but they sometimes feel in conflict. And I really appreciate, I'm sorry, I can't remember your name. Chris. Oh, I think you were on the call back in 2021 with MCOT, maybe. No, okay. I think there was a Chris on the call, but not you. No. All right. Well, you should have. It was a great call. I really appreciated your honesty and transparency in saying, look, we're human, and not everyone's going to handle every call right. Hearing that, I don't hear that a lot. Yeah, we're human, and not everyone's going to handle everything right. That's honest. So a follow-up question I did have from that is I am curious about supervision, with an understanding that we can always learn from situations. And we've had a lot of, and I'm sorry I'm going all over the place, but I'm excited to get the mic, so I have a lot to share. I know we're talking a lot about CIT training, and we all mourn the horrific incident of the man Alan Weber, who unfortunately was killed back in October. And from my understanding of the reporting, the officer who ended up firing his weapon and killing Mr. Weber was CIT trained. And things are going to happen. That doesn't mean because we have training everything's going to go perfect, or that nobody's ever going to be killed in an interaction. But I did have a question about how does supervision happen? What kind of review process is there on an incident of that magnitude? You know, going back now that we have body cam footage, is there anything that could have been done differently? What would we advise? I don't know if there's role playing. I know you do that a lot in the academy. And on lesser incidents, when we're talking about officer discretion, which is used for all of these calls, what kind of supervision and review process by mental health professionals or other CIT trained officers to say, how do we get better at what we do? You did great at this. Could you do this one better in order to keep improving? I'll leave it there, and thank you for listening.
Good with, everyone's good with the behavioral unit? Fine.
Oh, yeah, one question. I thought you said.
Why don't we,
Well,
wrap
sorry,
up?
just in what she asked, I
Yeah,
feel
she
like
asked the
is
question.
Well, I'm
not
sorry.
in our purview.
Oh, so you're talking about like an after-action review on that shooting? Yeah, so they didn't do one on that. I don't know the reasoning. I know our homicide division, they investigate all police shootings, and our internal affairs is also there. So that would be something that would be determined at headquarters if they wanted to have an after-action review on that, and maybe try and find out if there were errors made or, you know, if there were mistakes, whatever that was. I was waiting for something, but we never got it. Now, there were other police shootings. I know the Attorney General is involved in all of these now. So I guess maybe when she released her findings that she found that the officers were justified in having used deadly physical force, that was good enough for the department and they left it there. Could there be, you know, could we learn from that? I'm sure we could. You know, but again, I didn't know even that officer was CIT trained who was on that scene at the time. You know, that all transpired pretty quickly. I know we were there numerous times in the previous week, but that night, that situation itself really transpired in a few minutes once they went down the stairs. And again, I mentioned this to the last one, that I felt my officers handled it well. I don't think they had any other choice really, and as sad as it is and tragic as it was, you know, that's pretty much it. But we didn't do it after action. I don't know if they plan on doing that. That's about it. That's the
So
answer.
just last comment, I just really appreciate the transparency and honesty in your response, truly. I am hearing a little bit that a lot of the decisions about the behavioral health unit in this work is happening at kind of headquarter level. And so I did want to know, as a community activist and advocate, where, if we're looking to say, can we expand this program, is this start advocating for policy change at the headquarter level? Is this go to, or Rebecca stands still here, go to the ledge and ask them to say, hey, let's bring the 20% CIT training, let's pass it along and get that increased? Where is the best place for us to be advocating?
So
Who's making those
I would
decisions?
answer that as, it's certainly not me, but it could be both of those. It could be the commissioner's office, who, you know, they set the policy for the department for these programs, and or the legislature, because they're gonna somehow get the funding, or I don't know if the state provides funding for these programs. So it would probably be a little of both of those.
Okay, beautiful, thank you.
Okay.
I'm just looking for some clarification, and I think one of the words de-escalation was mentioned here, and because I think mental health sometimes gets confused with lots of other causes for conflicts, and my understanding of the police reform agreement was that every officer would be trained again in de-escalation training, which isn't necessarily having to do with mental health. That could be a domestic violence issue, it could be your locks was stolen and you're just upset about an incident. There's many, many times when there's a need to know how to help calm people down. And I know this is not any of your purview, I think, but I think we, as a community, want to know why, after all these years, it hasn't happened, that there's a real plan. They had a plan once for bias training, to train every single officer, and they got so far. They didn't do the whole every officer, but they had a plan. Every month, so many people, cohort, request, this is a request that, someone go up further and say the community is asking about this and when and how and why this hasn't happened, and let's do it. Because then 100% of the officers have some kind of training that would cover, I know you trained in the police academy, but there are new techniques and there's new things to be aware of, and I know in my profession sometimes I go to a workshop and say, why am I there? And then I realize I already knew this, but I forgot about it. I've been thinking about this and not that, and I'm glad to refresh my mind. We all need to be continually refreshed, and this is something that could help the officer, because when you're in this situation, it's very difficult, and they would benefit from it as well as the whole community. So I'm just asking about that.
So Helen, let me
Julie,
just say
you have
that,
questions on that side too.
they mentioned the transparency hub before, and on the
Right.
department website, there is a reform, I think, tracking
Right.
system on there. I don't know if that's what you're referring to, you looked at, but you can look and see the certain things that, and where we're at with some of the reforms.
I have
So
a
don't
lot of
know.
questions though, I'm sorry,
Okay.
Inspector, about the transparency hub. It is
Okay.
not, if you go and look at it and hit all these links, you'll find the links don't work.
Okay.
There was promises that they'd have raw data on there, it's not there. The IAB reports have not been up since 2021. There's lots of issues about keeping it up to date.
When was the last time you looked? Because they just refreshed it in February, and they did a whole new interface.
This is July. I looked maybe 2 months ago. I haven't looked maybe 6 weeks ago.
Because yeah, we had a whole like overview, like thin, large, and they had like totally redone it. So look through it. I think
I look at bicycles, for example,
Yeah.
and the word is on there, but there's no data about bicycle stops. The word is there. So I think it takes there's a lot to discuss about that,
Yeah.
and that's not the topic today.
Yeah, yeah.
And that's not their responsibility.
It is actually December.
Not theirs.
But in December, the PLAB's gonna have a whole overview of the stops.
Good.
So it'll be the December meeting, the inspector's gonna go over all that data with the transparency hub for us.
I think the traffic stop thing's up and running. I
It
don't
is,
think that's down, but there may be other sections that aren't.
Yeah. We'll take a closer look.
I appreciate everybody's questions, all the logistical questions, and all the questions you brought up, the professionals that are here, because everything is relevant and it means that everybody's concerned, and this is a needed program, and I'm glad that this is gonna take place. As a parent, as a resident of Green Lawn Manor, and as a special education teacher who has to constantly, twice and sometimes 3 times a year, take bias training, take mandated reporter training, take all types of trainings, stuff I have to redo and I already know, but it's important that police officers do it as well. I know that sometimes it boils down to funding, and stuff from the state. I'm not like new to this. My husband hopefully will retire this year as a captain in NYPD. So it's like on the other side of this, I'm like hoping he comes home safe every night. And they've dealt with many situations like this in the subways of New York City. But I myself, on the other side of it, being a mom of a child who has autism and a daughter who has anxiety and depression, I appreciate the compassion and the patience of the officers that came to my house for the incident. They didn't know that I was the wife of a captain. And it shouldn't matter. They handled the situation very well. I wish the guys were still here. They handled the situation very well. At the same token, though, when I spoke to, I called 911 and I just asked for help. I need help. My daughter is having a hard time and I need help. I gave them as much information to the dispatcher as I possibly could, and I think that is just very, very important. You have to give them as much information as possible so that they can tell the police officers who they're dispatching out what situation they're dealing with. So anyway, thank you, and I hope that we expand this. I hope that all the officers eventually do get the training, and I hope it's not voluntary. I hope it's mandatory.
I'm also volunteer EMS. Has there ever been crisis intervention training for the volunteer ambulance corps and the fire departments? I mean, unfortunately, sometimes we have to go into homes before an officer makes it there. And unless we're told violence in progress, we gingerly go in. And do you ever do training for other agencies that we could reach out?
So CIT is a national model that is a collaboration between law enforcement and mental health partners. I have no knowledge to know if there is a model for EMS as well. That would be something like at the FRES level, those bosses would have to look into get that training. Fire, rescue, emergency services. Because CIT does have some other models designed at different lengths, different time periods, different entities that could be involved. But I'm not a CIT professional. I don't know.
Because we were referring to EMT training at DASH. Would DASH, does DASH ever go to the different houses and?
So when the recruits go through part of their training and their onboarding process, they go through EMT training. Part of that training is the 8-hour clinical, so that's when they come through DASH.
Okay.
So it's part of their 8-hour clinical work for their EMT training.
So maybe Suffolk County EMS has to try and figure out how to do that as well.
And that was something that we created.
Yes.
So every Suffolk County police officer is an EMTB. And part of that, so when I did it years ago, I had to do 2 days, I had to ride on an ambulance. We incorporated with this unit within the 3 years, we said, you know what, we're doing all this work with DASH, behavioral health crisis calls on an increase. Let's get one of those days, so the recruits are going on an ambulance, and they're spending a day at DASH to see how behavioral health calls are handled. That was something that we implemented, yeah. So.
Is Family Service League interested in partnering with these other agencies?
We talk to other agencies all the time.
Yeah.
We're a
In
huge
terms of
county.
the fire.
Of course, we do lots of community presentations, and never did not provide a presentation on our
All right, I'll
services.
talk to my chief, maybe we can. 2 more questions. The CIT training, does that incorporate special needs population?
Yes.
Developmentally impaired and
So
stuff?
CIT, every time it's given is different. It's all based on who can attend and when. So it's not always the same peer that's coming. They have to have a list, and I'm just basing this off of my knowledge. I'm not in service, so I don't know how they do the scheduling, but I do know every time they do it, it's going to look slightly different. It has to be based on classroom availability at the academy, when it's available, all of that. So they have a list of peers, and they can reach out to that list of peers to say, hey, are you available on this Wednesday at this time? They schedule with Family Service League, when are you guys available? So it all depends upon who's available.
I don't think I'm explaining asking the right way. So we have developmentally impaired.
I'm sorry, yes, and
So,
are
are they trained in those?
so somebody from OPWDD
Okay, that's.
in that world, sometimes it's New York Start that may come in.
Okay.
Somebody comes in, they will have from every facet, some organization who's ever available come in within those 5 days.
I
Yes.
have one more question. So you said something about you find out when Narcan has been administered. So in the home, if a family doesn't report it, you wouldn't know that.
Correct.
So it's only when other agencies administer it.
It's
Does
when
that
the
mean-
police department or EMS are involved.
Okay, all right, that's what I wanted to know.
Yes.
Thank you.
Well, guys, been waiting a while.
Sorry. He's got a little arm.
That's right.
Okay, go ahead, and then we'll take your guitar.
Yes, how you doing? My name is Conway Jones, president of Leaders in Houston. But I'm also a 7th grade world history teacher. We all know, especially with our young adults and teenagers, they go through a lot of, should I speak up a little louder?
Yes.
Yeah.
So I'm also a 7th grade world history teacher. I know for like a lot of middle schoolers and high schoolers at this time, they go through a lot of like mental health crisis. A lot of the programs that you said today was actually like, I think like pretty cool. I think it is a better step for us in a better direction. But the next question I would ask you all is, would you ever think about trying to get these messages out of the school district? Because I know the biggest thing that you want to do is start talking about collaboration. This is community-esque type of environment, as well as when you start collaborating, that's when innovation starts to happen. And I think when young people start becoming involved in the planning process, when you start hearing new problems, I think that's when you become motivated, just as individuals. So I wanted to ask again, have you ever thought about talking to like the neighboring school districts such as?
We already have.
Okay.
I can tell you, I
Yeah.
spoke, they have, I know we have, I spoke with, Walt Whitman High School. 2 years ago, I think, a year ago maybe. They had asked to come in, and it was just a situation like this, where I was speaking at a community event. There was a teacher in the classroom, and they said, would you please come? They reached out to their principal, and the principal said, come on over. You know, that's how this is all going to work. I believe at some point we had reached out to the superintendents, right? And
We have a lot of partnership with schools in terms of family servicing, but one of our strongest partnerships are with the school districts. And I think one of the greatest things that we've been able to accomplish with DASH is to really nurture those relationships, develop referral pathways, be able to close the loop. But, you know, and again, going back to historically versus now that we have DASH, it would be traumatic oftentimes for kids to be brought by the police in handcuffs to CPAP, be separated from their parents, be behind a locked door. And if we can prevent that, like we do risk clearances all the time. If schools are worried about someone and it can be handled at DASH, we will do that and collaborate and communicate with the schools. But we always welcome to continue to educate and continue to talk about what's available.
And also our SRO officers, so our school resource officers, are well aware of us. Like I said, we go in and we speak when they are going through class. They reach out to us. They can let us know if they have a child that they feel is in need of behavioral health help, and that's what we all work on. What? Little Timmy. I know. I always poor little Timmy.
I would also like to add on to that point as well. I know since we are dealing with like teenagers, they won't say everything that's on their mind, especially to adults. So I guess like how would you attack it? I know it's a very hard question to ask, especially being a teacher, but how would you guys attack it, especially when we're trying to like I guess stop this this big crisis with mental health that's going on just throughout the country, and how can we try to get a hold? Because I know you were talking about intervening, that's how you stop a lot of the problems that actually do happen. So how do we take a step forward, not only as more in a collaborative effort, because I know it's not extremely one-sided. I don't want you all to have that on your plate, because I know you need both each other on this idea. So how can we actually just kind of like build on this idea?
Clinically, I was trained you can't just assess a child. This is the family. You have to work with the family if you're working with the child. And I think that we embrace that model. That's an important part. And collateral, like other people involved in somebody's care and life, like the school, or if there's another provider involved, talking to those partners is very important to us to be able to really assess a person or a child.
I would say a couple things, right? In addition to that, so I think that's spot on. But it's all about relationships, right? Relationships, being able to build trust, engagement. I think one area of interest that I have, and I know we're not there yet, is I don't think we move upstream enough. I think we're still too reactive. And particularly for those, like when you say anxiety, depression, all those internalizing disorders, it may not be the aggressive person acting out in class, but we don't screen kids early enough, and we don't do it in a uniform way. And being able to have partnerships like school districts, and if someone screens positively, how do they then get connected to have the services that they need? So I think, so I think in some schools I think are afraid of liability or whatever it may be, but I think that's something we all need to tackle.
You can do your research if you'd like. It was something I was interested in a little while ago, but we focus a lot in this state in particular on physical fitness, right? Like football, lacrosse, blah, blah. But we don't do a lot in school. This is what happens when you get me from behind a computer. Watch out. No, like there's not enough kids aren't taught about mental wellness, mental fitness in school. And the Midwest has some pretty interesting programs. I'm not aware of any of it being brought east yet, but I find it to be like fascinating as somebody who is not coordinated in any way whatsoever, didn't participate in physical fitness as a child. So I think, like, you know, we have to, and listen, kids are hearing about it, right? They know. I'm not gonna lie, I really didn't know about suicide when I was growing up, but our kids are hearing about it now. It's like they're learning about it at a young age, but we in the schools partnering have to have more training classes, teaching children about mental fitness, the good feelings, the bad feelings. There was some program they were calling it like monkey brain, like a very interesting little programs that they have in the Midwest. So just do research and be activated. Okay, there you go.
We did 40 presentations in Nassau County this year. Suffolk, we have NAMI as well. So, and what it does is it differentiates because there's curriculum programs about mental health, but it's the health teacher, and it doesn't really talk about real emotional anxiety. And part of the presentation is a peer does a presentation. A peer is an essential part of the whole mental health education process because it's Liz, it's adults, it's people talking. It's not that other kid, that other young adult is going to relate to other young adults in a whole different way, and they're going to talk a whole different way. So there's a lot of programs out there, and again, ending the silent family. Again, our biggest challenge is AP classes versus mental health program. How much time is in a day? But schools are hugely hunting to us now. It's a different world. So I'm thankful for that. We got more phone calls this year than we ever had.
But like we're talking right here about now like the schools and everything. And I know in our community here in the town of Huntington you have difficulties getting into these school districts because they don't want you around. And they don't want, and I mean, I know that for a fact. Like if you go to, I won't mention it here, but I can tell you right now, 2 school districts will not let you in the door. Because, and I can understand that fact, and people have to understand that they cannot expect you to go in somewhere where you're not wanted. Okay? Miss, you're looking at me like I have 2 heads.
So this, yeah, this is it. But from down here.
This is more of a compliment than questions. And first of all, I'm CIT trained. My mate's Sam Conklin. I went down to Tennessee. The reason why I'm trained, I'm a former correctional officer from the state of New York. Now I'm a family member of somebody in the system. So I have a son with mental illness that was abused by the 2nd precinct when he was arrested, 20 some odd years ago. And it really put him into a hamper. And that made me become the mental health advocate that I am. I commend you guys what you do, because I run a NAMI affiliate, and I refer families to call the precinct, call the local precinct when there's an emergency, and also the DASH. And you all do a great job. And it's one of the NAMIs that work to get DASH up and going. We appreciate. And it's one of the NAMIs that work to get CIT training to Long Island. We appreciate you all. And I know law enforcement is a tough job. It's not easy like a lot of people think, because not only are we law enforcement, we're also social workers, chaplains. We have to be that big brother or sister at times. So I thank you all. Keep up the good work, but let's get more CIT, and let's enhance the DASH Center bigger.
Thank you.
President NAMI Central Suffolk Long Island. I have a couple of things. Number one, we have a new initiative, NAMI on campus and high schools. I've been in contact with a lot of the schools out here, as well as a Teen Wellness Summit. So we're doing a lot of programs and initiatives in high schools and colleges, as well as we were just out of BOCES, the Eastern and the Western BOCES. So we are working really hard to change that. Also, we're having a new program for elementary
trained this summer, we're bringing it in from the Midwest. And
Oh,
so
nice.
they said, when do we, I'm on a youth committee in Suffolk County, and they said, when do we start training? And of course, us older people said, middle school. They said, no, elementary school, talking about substances and other things. So we are bringing that program into schools, and we do have a lot of connections to schools out here. I'm gonna tell you some of the good news is, and I understand how tough the job is, but I was with NAMI Queens Nassau for a long time, and we're here for less than 2 years in Suffolk, who had no NAMIs for quite a long time. And so, one of the things that I used to get a lot of, and I still get crisis calls and have a lot of calls every day, you're doing better. Usually you were doing worse, and Nassau is doing better now.
I know, now there's no
Suffolk is doing far better, and I do actually relate to a lot of families who have people in out of states. And I'm gonna tell you, this is a dream place, I'm not saying we can't do better, but this is a much better mental health system than many of the states that we're trying to get the kids help with families who live here. So I'm just telling you, I see the bigger picture, and I thank you for what you do, and hopefully we can continue to partner with you as well, because I do actually send people to DASH and to Family Service Leagues, and I get feedback, because we don't leave families out there alone. We have a lot of family, also classes and support groups, Family Surviving Suicide Loss, we have a lot of stuff that we go through.
And we're free.
And we're free, everything is free. And
We're
one last thing,
grant-funded.
we are working with clergy and faith leaders from all over, because when you are stressed, who do you go to, what people of faith? So we've been doing a lot of stuff as all NAMIs have been.
We have talked, so
I know
we
that,
look
I know
forward to
that, I said to
continuing.
her,
If there's any more
people.
snapshots that we can make, because I get your emails and I share them with the staff,
Thank you, I know that, I said to her.
Thank you, guys. You have something?
Yeah.
One more thing?
Yeah.
We're gonna end it with Jerome. We're at 8:03.
So, as I've been listening to a couple of the questions, right, I think one of the things that what I'm hearing folks say, which just comes to like the CIT training, is, you know, the precinct level advisory board, we are tasked with trying to, you know, build the transparency and community trust, build that trust between the police department and the community. And what I think a lot of the questions were circling around, specifically the training, was relative to how can the community trust that when they are making a call regarding one of their loved ones, that the officer that's going to, if it doesn't get the call diverted, which the call diversion program is great, gets call diverted, goes to DASH, and then like, you know, but how can they trust that the person that is gonna come to meet them at that door is going to understand what their loved one is going through? Because if we've ever experienced someone that's been hypermanic, or someone who's in a state of psychosis, the reality is not necessarily the same. And so the natural reactions that, you know, some officers might have with regards to someone's potentially posing a threat, and I'm not talking about like a loaded gun pointing at somebody or something like that, but like that might not be beneficial in actually de-escalating the situation. And so I know, sir, you mentioned that like the CIT training program isn't necessarily meant to be that all officers are trained in that, right? But then that poses the question, what, just simply, how does the community know? How does the community know? And we know the examples, right? Rochester had Daniel Prude. Brother calls up, says, my brother is clearly going through a crisis right now. Can you please come and help me? That brother ended up dead, right? With the spit hood over his face, right? The officers may have been well-intended, but clearly they didn't know. I believe SCPD probably is much better trained than Rochester Police Department. I don't know what training they're having, right? But the community, if I'm representing the community, we don't know that really, right? Like we don't know what's going on. So that's just a larger scale kind of question. How do you get the community to have that trust that the officers are prepared? The second question, I do have a couple more questions. One is, and this is specifically to you, Inspector.
do we know what percent of precinct 2? I know 20%, countywide, but what percent precinct 2 is?
Percent, I don't know, you know the number?
Is it still, is it about 20%?
20% is across the entire.
But I did look at the stats, 55 second precinct police officers. Which reflects 20% of the precinct?
Well, we
I don't know,
no.
I know the number, but I broke it down to
160.
the number. They have 160.
Well, that's police officers, yeah.
Okay.
So that's.
So they have 133 officers, so they might be a little more, you know, the 20% is the overall department. When I look at our patrol officers, we have 2,500 patrol officers, and I'm just saying approximate, and 500 is CIT trained, that's where we get our 20%.
I don't know where
But
that- I
what
don't
I'm
know where
saying
that
is, I
number
did
was.
look at the specific
I
numbers
didn't-
for the
we
second
didn't
precinct
say
coming
that.
here, and I saw that 55 second precinct patrol officers are CIT trained. Okay. And, so you brought up that, you know, in the case of Alan Weber, and I know last time we actually had somebody here who was actually a neighbor to the person. They were pretty, I don't know if she's here today. But the question that I have is, like, in the case of Alan Weber, where there were people, neighbors calling days and weeks in advance, did that do we know if any of those calls were diverted to the Family Service League? Were any of the interventions that we discussed today, did they meet its way in that situation?
My answer is yes, I believe that did occur, okay, but again, I told you last time, I didn't wanna get too involved in this case, because there's probably some litigation still going on, but I do believe they used the diversion or the program here, at some time prior to that day, that this incident happened.
And this is not necessarily a question, but one of the things that struck me, and I think that Emily had mentioned, I believe it was Emily, yes, was that, you know, is there an after action review? And I know you mentioned that it basically comes down from it seems like the top. Like if the top does an after action review, then it makes its way. And I'm wondering, is there space within the precinct, and I know you don't control all of the precincts, so let's just say in precinct 2, is there space for that type of after action review to occur? Not necessarily for the big cases. I understand there's a lot of litigation for the big cases. I understand there's litigation for the small cases. But what happens where that just gives officers the feedback around what could have been done differently, what could have been done better? Because what I'm hearing is if the top doesn't do an after action and send down their recommendations, then are there any, like, is
So
there any feedback given?
yes, I can answer. So, in individual squads, you have a lieutenant who runs it and sergeants that, you know, are in charge of supervision. So if they have let's just say a significant incident, all right, they're probably gonna discuss, especially if, you know, if they think maybe something didn't go right, they're gonna discuss this, and they'll discuss it amongst the supervisors with the officers that were involved, and say, hey, how can we improve on, you know, how we handle this situation? That's like on an everyday basis when we handle something that, you know, we think may have gotten out of control. We're always looking to improve the way we do things. You know, that's just how we go about things. We don't, you know, we obviously don't want to make mistakes, you know, because in our profession, that doesn't really work too good. So yes, you know, they can do it in their squad alone. We could do it precinct wide if we had, like, give you an example. I don't know if you remember the legal seafood incident at the mall where there was a carbon dioxide leak and a lot of EMTs and officers went in there and they became sick. They did a big after action review at the precinct from the, I think it was maybe the captain or the lieutenant who handled that situation. He gave the presentation and a lot of the bigger bosses went there. So we didn't, you know, make that same mistake again by people going into the building. They didn't realize that there was carbon monoxide in the building. And as people started slowly getting affected by it, it almost became a mass casualty incident. There were a few, I know one person died there, but it came close to maybe a couple of others. So they did do a review on that. But when you have something like that, yeah, we usually would do something, you know. But again, with the Attorney General getting involved with this one, I don't know why we didn't do it. I don't know if they were satisfied with her report on that. I mean, her results came out pretty soon after that because they released that videotape within weeks of things, so I guess she was comfortable. I don't really know. I can't really explain why we didn't do an after action on that one. But I know we've done with other serious incidents like that.
If I can just add on to that, Inspector, you know, while I was as a patrol supervisor, it was just up and coming with the body cams. So the patrol supervisors do audit body cam footage monthly with, I don't remember exactly how they pick which officers they're gonna audit, so they audit video, body camera footage, and then they'll review that with the officers. So they're gonna watch what's transpired. It could be a traffic accident, it could be a domestic dispute, a variety of different calls, and they'll review that footage, and we're gonna see, you know, did the officers follow our protocol? Is there something they could have done better? Maybe, you know, and we'll critique. And I mean, I do remember, you know, I left patrol shortly after as that was being implemented, but that was you know, one of the ways. On a smaller scale, we do review what's going on in the field with our officers.
And so just as a recommendation, just broadly, is, I don't know if the community knows that. I don't know if the community, oftentimes we know something's founded, something's not founded. The officers didn't do, it was a justified killing, it wasn't justified, right? And it's just so black and white. And I think members of the community wanna know that, and I understand it's a really thin line, and I give you all the credit involved. It's a really thin line, because you can't set yourself up to a point where it's gonna be like, we're getting a lawsuit now, right? So I understand that. But it would go a long way for the community to know that there are processes in place and that there are everyday learnings that are taking place to help the officers who are unbelievably good officers grow in their role and learn from experiences when things don't go well. And I think that's the place, even what Emily said about like scaling the program, like being able, when I ask about the data, and there isn't able to say, these are the metrics that we're using, whether we're there yet, whether we're not there. This is the data that we're looking at. And so what it feeds back to us is there's a lack of transparency. There's just and that's not intentional, unintentional, but what you just said about like, you know, there is this process in place, and maybe high level, what we do end up finding, that goes a long way with building community trust. And this is what the PLAB is here for.
Exactly.
And so that's why I bring it up.
Yeah,
Well, and also the community meetings, because I'm always encouraging people. I've had people come, you know, this is the first meeting I've ever been to, and this was so informative, and this was great, and I'm gonna come again. And the first thing I tell them is, well, tell your neighbors to come, because if we could get the word out, like you said, you don't really hear about all this stuff, but if you come to the community meeting where I speak, and well, thank you, and a lot of times we have special units, and I wanna thank them again tonight for what they did here.
Absolutely, incredible.
But it's all part of it, and, you know, we have a decent amount of people here, but there could be more.
Right.
And, you know, I encourage that all the time, so, you know, that's
Right.
one way we can do it. If there's probably another way, you know, if you got an idea, that's what PLAB is, come to
Yeah,
me,
we're
maybe there's
gonna-
another thing we can do, I don't know. You know, another way we can get, you know, the word
I
out.
have a couple of ideas, but I
Okay.
appreciate
Well,
it.
we'll talk about it.
All right, so officially, this is the end time of our presentation tonight. Our PLAB board was going to be staying till 8:30 to do some new business, but we have a decision to make. Inspector, do you have to run out right now?
I can stay.
Okay, so we had some additional questions for the inspector that we had submitted previously. Thank you so much to the mental health team. You are fantastic. Thank you so much to all of you.